Hi everybody, we are going to get started with our next speaker. Dr. Haleh Ghazizadeh is board certified in general adult and forensic psychiatry and has a master's in public health. In addition to maintaining a private practice, she is an assistant clinical professor at Columbia University College of Physicians and Surgeons. She consults to prison systems, state organizations, and public schools, and she is a dialectical behavior therapy trainer and consultant for Behavioral Tech, the training company developed by Marshall Linehan. Today she'll be speaking primarily about psychopharmacology of BPD. I'm actually hoping that in one of our future conferences we'll have her back presenting on other things, other matters on the psychotherapy side. Although I'm very happy to have you here with us presenting on this. Without further ado, and correct me if I'm saying this wrong, Dr. Haleh Ghazizadeh.
All right, thank you. Well, thank you, Seth, for inviting me, and thank you, Emily, for helping with the slides, and thank you for the conference. I'm really excited to be here, and I just have to tell you, I'm really excited that my 12-year-old son kind of vetted me before I came here. He asked, as I was driving him to school, are you ready? I said, yeah, and he looked at me and he said, well, it's really too bad you have that pimple showing. You might want to, too bad you couldn't get any cover-up and put it on there. I said, yeah, that's at home. And he said, and make sure you wear the right lipstick. Having seen Leslie Stahl interview on 60 Minutes, and she had this little thing on the side, I was still kind of ruminating about that. So I said, I have the right lipstick, let me show you. And as I went, I realized my purse had spilled all over the back of the minivan, and my favorite lipstick was underneath the seat. And so I was able to retain it, and so I hope you can see my lipstick in the back. And we can get started. So, we're going to be talking about impulsivity and aggression, and really the idea that I have as not only a DBT therapist, but as a psychopharmacologist, creating the space to talk about it, to find a way to help people see this as a problem that we are collaborating on solving. And I use medications as a tool, but just one of many tools. And I think my talk will piggyback really nicely on what we have already heard this morning, which is either serendipity or just great stuff from all of us, because we didn't confer. So let's see. Okay, so let's just define impulsivity. Dennis the Menace says, by the time I think about what I'm going to do, I already did it. Yeah. Okay, I know people like this. They are teenagers, yes, and a lot of inmates. A lot of people who are in secure settings think as they do. All right, that looks like it doesn't work, right? Okay. Aggression. I'm not talking about instrumental violence. I'm not talking about predatory aggression. I'm not talking about being in a hypo-aroused state today. That might be a topic for another talk. I'm really talking about what happens when somebody is emotionally aroused and acts impulsively and either aggressively or not out of that aroused state. Okay. When I'm thinking of medicating people, this quote really has a nice way of talking about how I think, as opposed to the biosocial theory that comes from DBT, where there's emotional vulnerability in an invalidating environment, and over time the transaction creates emotional dysregulation. When I'm thinking about how am I going to kind of look at somebody in a vulnerable place and think about medicating them with the purpose of kind of slowing things down, this quote really hits the spot for me. BPD is an emergent phenotype, principally reflective of a complex interaction involving diminished positive emotion. Yeah, they're nervous, they're anxious, they're more depressed than people without DBT in my office. In relation to negative emotion, yep, joy is fleeting. Joy isn't sustained. People worry about when it's going to go. And there is a diminished activity of the modulatory constraint system. We saw that today, that they have trouble putting the brakes on. So they plow through. And so when I'm thinking of how am I going to offer meds to them, if somebody meets this phenotype, then this lecture is about how I think about them. Okay, the APA has 3 practice guidelines for the psychopathological dimensions that are the main targets for BPD. You've heard about some of them today. There's affective dysregulation, there's impulsive behavioral control problems, and there's cognitive perceptual systems problems. They recommend fluoxetine, a bunch of anti-epileptics, mood stabilizers, and 2 antipsychotics, olanzapine and aripiprazole. For cognitive perceptual symptoms like paranoia or rigidity or kind of even a locked-in depressed state, they recommend olanzapine. And I just want to start off our conference by saying I really rarely prescribe any of these. I really don't. I get people who come to me on all sorts of cocktails. In the last few weeks, I've had somebody on 10 medications, 5 of them mood stabilizers. I have people who are not consented for these medicines. They have no idea the side effect profile that is, perhaps coming their way. And I find that in an outpatient population, people are loath to gain weight. I don't want to give them metabolic syndrome. I don't want to be measuring their liver functions and looking for blood dyscrasias. I find these medications minimally helpful for people, although I would like to say there's always a great story about 1 or 2, and so they're not my first line go-to medications anymore. There's always a phenomenon of medications being new on the block, and we really want to try them. We really desperately want to help people, not be miserable. And yet, I think the jury's out. These medications, as we heard from Dr. Wu earlier today, they offer a little, but at a huge cost. So I'm not going to be spending a lot of time talking about these meds today. But I'm just going to give you a little bit of data for why they're supported. So basically, NEW had a study where people had reduced activation of the prefrontal cortex, no surprise now. They had fluoxetine, and their aggression scores went down. Olanzapine has shown, in combination with DBT, to decrease depressive symptoms, anxiety symptoms, and decrease the frequency of impulsive behavior over DBT and placebo alone for an 8-week trial. The Cochrane study showed contradictory data from 14 studies over 672 participants on the efficacy of mood stabilizers, anti-epileptics for people with borderline personality disorder. So for every study that showed, yes, it's effective and helpful, there were other ones that showed that it wasn't particularly helpful. And rather than spend time weeding through what is helpful or what isn't, I'd rather spend time telling you about what my current thoughts are. So we're going to move on from that. But it's there for your review. Okay. I really like having the option of prescribing medications and doing DBT. It widens my toolbox, if you will. And so some of the things that I like to do is to really carefully look at the behavioral chains of my clients, to assess for the critical links, to really understand the behaviors that are the end points of their chains, and then to kind of really try to slow that process down, to slow it down through mindfulness practices, to slow it down with creating awareness, allowing for distress tolerance skills, emotion regulation skills to come into play, or even talking and kind of planting a seed that mindfulness practice can lead to more joy, and really hammering it out, having a firm belief that change can happen. I also really want them to accurately express how they're feeling so that I really understand, and when I'm validating them, that I really get it. Not to have kind of approximations for what it's like to be them in these moments, but to really understand. And we might spend a lot of time. And I invoke every validating person I ever had, because sometimes my urge is to jump to change and to jump to move them along, and yet I really have to put the brakes on myself to understand this moment for them. We talk a lot about goals, self-concept, and values, who they want to be, what principles guide them, who their role models are, and try to think about ways of signaling this impulsive moment and marrying it to these goals. It's quite difficult. And then I offer medication to maintain focus and emotion. Focus and attention, during intense emotion. So we've all seen these pictures before. Reasonable mind, emotion mind, and wise mind. Wise mind is that combination of emotional knowledge, cognition, and action that results in true understanding, compassion, and real progress towards somebody's goals. This is from DeviantArt. So imagine a train barreling along, right? The person's impulsively going to act. This is like the therapist on steroids, holding them, right? So yeah, I just loved this idea. This was not me in a different life, but this is what I feel like, right? It's just like holding them back. And hopefully the A's can be them as well. All right, so how to make them stop and listen and look at their environment, listen to their heart, kind of take in what they're saying. I like to think of medications as kind of the path to the path of mindfulness. It's kind of that net, what might help somebody get to the place where they can start learning the skills. So I don't know about you, but sometimes people are so aroused, their SUD scores are so high, and if they're aroused so quickly that they can't actually think to utilize the skill when they need it the most. And they can't get distress tolerance skills down so that they can bring themselves to a place where they can think. And so for them, medication might be a particularly helpful place. There are other people who can do it without meds, or have enough of non-intense emotional moments that they can then get learning down, they can get new experiences, they can feel confident to try them during these other times. But there are some people who have such a high rise in their emotionality that they can't. Okay, and in the chain, I look for these little tiny links. I can't stand this. Fuck it. I give up. It doesn't matter. I am never. Whatever. You should. He should. Any of those things. And I see these things as little permission slips to go the rest of the way. Right? And so these are the things that I'm really actively looking for. And these, by the way, will be my objective measures when I've medicated them. Can they stop in this moment? Can they think? Can they do something different? Do we barrel through these moments in their behavioral chains, or do we actually spend some time growing and slowing the moments down, either preceding, during, or after these? And if we do, I feel that we're making progress, and hopefully we'll see that in their behavior as well. It's like directing treatment to the front end of the train, okay, the front end of the behavior. I was talking to a sheriff officer who works in California, and he's a sergeant and he works in their segregated housing unit. Normally, when I was working at Bedford Hills Correctional Department, our segregated housing unit was just really out of control. You have people who are more violent, less able to control themselves, and you have all the newbie corrections officers who have to do their tour first, who have to kind of get hazed, hopefully in a non-lethal way, right? They get hazed and then they make it through. So I said to this guy, well, how do you manage your shoes? How are they as chaotic as the shoes I've seen? And he said, oh no. If our guys do anything, we just recharge them with assault, and because we have a 3-strike rule, they're looking at 25 years to life. So they do nothing. Now that's getting them to modify their behavior by consequences. The consequence is so high that they're not going to, that those brakes are shackles, okay? They know. So, but it doesn't teach people to kind of learn and pull on new behavior in a different environment. It doesn't. And unfortunately, in corrections populations, as soon as you layer on the punishment so much that there's no meaning, it loses its ability to function, right? So even if you're working with corrections populations, you still are going to have to work at the front end of the chain eventually. It kind of just gets you going at the beginning. But it's an important concept. So when you're working with violent people, if you can construct consequences, or impulsive people, consequences that really are meaningful to them, it might help them rein in behavior that they sometimes can. Of course, if you don't do this front-end work, they're ultimately going to fail at it. Okay, you've seen this slide before, how happy I am that it's been up. Okay, so this is going to direct us to where I think pharmacologically we need to go. So we have the frontal lobe, which tells us how we know what we're doing in the environment, our consciousness. It's how we initiate action in response to our environment. It's involved in judgments we make about our daily activities, controls our emotional responses, our expressive language, assigns meaning to words we choose. It involves word associations, and I like to think of it as the area of sober second thought. The amygdala, as we know, is involved in emotional learning. The amygdala, these nuclei are the red ones, and they're involved in emotional learning and assigning salience, and they also connect emotions to senses. And in some, and I like to think of them as kind of the implicit memory, the body memory, the non-word memory, the memory that actually perhaps is less amenable to psychotherapy, to word treatment, okay? And it connects to the hippocampus, which are these horseshoe, they look like hands, like if the amygdala, the thumbs, like the hippocampus, and the hippocampus, or the hippocampi, I should say, have these afferents that go all the way around the brain and connect. Now, what's really interesting is that if you have chronic stress, and I'm going to postulate that our people with borderline personality have a lot of chronic stress, that changes happen in the relationship of the amygdala to the hypothalamus. So for instance, let's say you're on a roller coaster, and you like roller coasters, right? And you're going to go down, and you feel that rush of energy. That is your glucocorticoids jumping up, right? Your adrenal glands go boom, you're excited, up you get. It's nice for the brain. The amygdala gets all stimulated, and the hypothalamus is making all sorts of associations. I'm at a theme park, it's wonderful, I'm with my friends, there's popcorn, it's sunny, blah, 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 I love the thrill, a little scared, right? All these afferents grow. Over time, chronic stress ends up damaging the hippocampus, damaging the location for where we retrieve memories, attach words, have narratives, and actually increases the amygdalic memory. So the amygdala, the wordless memory, the fear, the tension, all right, ends up getting out of proportion to the hypothalamus. And I don't know if you have this experience, but I have people who say to me, oh my God, the fear of being seen is so terrible. They can't really articulate the fear of being seen. Or the shame is absolutely all-encompassing, and they have trouble talking about that. Or, I don't know, something really bad will happen, and then they're overcome with an emotional, physical experience that somehow is bereft of thoughts. And I like to link that to this knowledge, but I'm just linking it. I'm not really certain that is what's happening, but theoretically, it makes sense. Okay, so just as a review, we know the frontal cortex, especially area around the eye, gives inputs to the amygdala, and we know that chronic stress changes the amygdala and hippocampus, and this middle point is what's interesting. If you take people who are not borderline personality disorder, but might have a more neurotic style or something, if they actually either suppress their memories, the combination is they usually suppress them and then they ruminate about them, they suppress them and they ruminate about them, that over time that actually leads to a lowered mood, heightened anxiety, heightened depression, which of course leads to stress, which then is this like positive feedback loop on further damage to the ratio of long-term potentiation, which is growth and health of the amygdala and the hippocampus. So I really work very hard to break apart rumination and to stop suppression, and so much of the mindfulness techniques that we use in DBT I think are helpful in those regards. Okay, I'm not sure I need to say more about this. Okay, this is a really busy slide, don't freak. Just kidding, I shouldn't freak. Okay, I fashioned this slide after Marcia Linehan's slide on suicide, because I was thinking, oh my God, treating aggression and violence, especially with people who have borderline personality, is such a huge task. Like, it is so big. And so I thought, all right, anytime I read anything that shows any piece of that for people with borderline personality, I'm going to organize it into these three components. Okay, and I'm just going to touch on a couple things. All right, the first is, let's think about, I'll just pick a couple points for aggression. There's a demographic for aggression. People tend to be more aggressive when they're younger. Males, 18 to 24, even younger than that, tend to be really much more aggressive. Interesting fact with testosterone. A lot of testosterone actually lowers the pain threshold in people, and it differentially puffs up the amygdala and brings down the hippocampal controls. So a lot of testosterone, in a sense, is like a lot of stress, which also is interesting, and it might, I love it. I tell my husband, yes, testosterone decreases your pain threshold. That's why men have a harder time tolerating pain than women, and why they might be aggressive out of it. I just think it's very interesting. Okay, other interesting things. I'm just going to tell you one piece. So we've talked about, there's genetic predisposition, there's genetic control, or at least lots of things are being shown to be kind of genotypically and phenotypically present in borderline personality disorder, and there are ways in which genes and the interaction and the environment interact as well. One interesting study showed that an individual who's homozygous, which means they have the same short arm for a serotonin transporter promoter, are more likely to suffer mental disorders, but only if they were maltreated as children. So now we're looking at genes and seeing that the environment actually affects gene production, which then has a phenotype, or at least has a presentation for showing a predilection for mental disorders. I think it's really interesting. Our understanding of the brain and its plasticity is really changing. Oh, just to go back, when I'm prescribing medications, I need to know what's the age of the person, what's their biology, how does their body metabolize medications, what family members have benefited from meds or not, as well as what's their learning history. People have learning histories to medications as well. And there are people that come in and say, no matter what, I will never take X, Y, and Z. So I'm always trying to think of how do I look at kind of an ecological perspective of violence and an ecological perspective of the patient that I'm treating. What I think is really interesting here is all of these things, all of these lists here actually show differences in processing between borderline patients and normals, if you will. And I put us in quotes because all of us can be both at certain times, right? And then the last point is really important for correction settings or any other secure setting or residential setting, that how somebody is impulsive or aggressive or expresses themselves is a large part determined by their environment. The roles, the models that they were raised in, people who are gang affiliated, you're going to need to really work on affiliation and get them affiliated to you as a therapist before you start changing their behavior, things like that. You might not think of as being very important in aggression and violence, but it's hugely important if you're looking at a youngster who's in a secure setting and who might be gang affiliated. There's a lot of studies showing people who are watching violent video have hypofrontal perfusion. All sorts of things that affect people's willingness on some level to work on violence and recognize violence as a problem. So when you talk about somebody or when you talk to a person who is violent, or you're trying to treat violence, we have to know, what is it about violence that works for them? What is it about impulsivity that they're attached to? Just because we're all sitting here saying it's got to go down doesn't mean it hasn't been effective in their lives. I had a role play that I was going to read to us later on, but I'm not going to get to it, I think, which was going to demonstrate how violence was completely reinforced in the family system, and how on some level it had some, there was a little bit of ability for the person to say, well, what can I do to get somebody's attention? Violence is going to actually do that. So when you have somebody who's impulsive or violent in the room with you, you can't just assume that violence is bad, violence doesn't work. There are so many ways in which our culture supports violence. War, football, violence, at least you won't mess with me in this moment if I'm tough. I might not care about the relationships I don't have later, but right now, you stay away from me. These things are effective in people's lives, and so if you're trying to medicate to decrease arousal in people who are violent, well, they might really feel from their learning history that they need to stay vigilant. You might get non-compliant people in that moment because you don't understand the utility of violence in their lives. So I just put that up here to think that, it's not an easy thing to just talk about decreasing impulsivity, decreasing violence, that there are all these different factors, and we might have a chance to talk about them later. But the other thing that happens in a lot of the people who I see, at least in correction settings, is that a lot of people's parents whipped empathy out of them. That in a dog-eat-dog world, having empathy is something that makes you weak, or is perceived as weak. And so there's no way you're going to make any impact on dealing with people who have had issues or experiences of puppies being killed before they are stomped on or things like that to make them tough. You're not going to be able to actually work to reduce violence until you work through not only some of that trauma, but then go back to work on attachment and empathy. And that's a big, long, complex task. So just to kind of cut that short, I just want to just talk about the other side, that it's just not so simple. Okay, now let's move on to what I think is a little more interesting. Okay, and I've got to go fast. We've talked about dopamine and serotonin a lot. I want to kind of leave those alone. I want to move to norepinephrine and its effect on energy and alertness and concentration. And I want to talk about those medications that are more involved, because remember, I'm trying to bring my clients' focus to this one moment. If it's that one thing, and it's that one thing when they're aroused, or that one thing when they're sad, or that one thing when they're depressed, whatever it is out of which the impulsivity comes, I want them to be able to attend to that. Okay, this is a complicated slide, but basically what I wanted to show is that on the left side is intoxication. If you have too much of an agent, these are the symptoms you're going to have. It's in your slide set. If you have too little, the symptoms you're going to have are on the right. And the interesting thing is glutamate and GABA are two neurotransmitter systems that regulate inhibition of the brain's excitability and excitement. And so we need to talk about these medicines as we're talking about medicating for impulsivity and violence. Okay. Glutamate is the main excitatory neurotransmitter. It's what gets, when you're on the roller coaster, right? And boom, you get excited, glutamate goes up, all right? But if you have too much glutamate for too long, it has neurotoxic effects. And so this has led Husseini Manji, formerly of the NIMH, to say that mood disorders might be atrophy of the brain cells. It might be that there's too much stimulation, okay? Glutamate receptors in the correct amount cause the long-term potentiation, which is learning through the hippocampus and the neocortex. If you don't have the right amount of that, how are you going to get new learning to happen? Right? So these are the things that are interesting. And lamotrigine, okay, is actually, lamotrigine is a newer mood stabilizer, but it actually affects glutamate. Depakote does too, just to throw some old meds out. Okay. Oh, I'm sorry. I jumped the gun. GABA affects GABA, and GABA's the brakes. So let me say that again, since I just said it opposite. GABA is the brakes. Lamotrigine and Depakote are thought to work through potentiating the effect of GABA, and they work on the GABA receptors, at least we think they do. Okay. Now let's go to alpha-2 catecholamines. These definitely have an effect on the brain, and I'll just mention their effect on the body as well. Regulation of attention, behavior, cognition, and impulsivity by the good old prefrontal cortex. It's the top down, it's the brakes that these medicines can offer, and it's why they get used in conjunction with stimulants for ADHD. Okay? So, they cause vasodilation of the arteries peripherally, so they cool the blood. The blood gets pooled in your extremities. If the blood is pooled in your extremities, you don't have as much in your heart to pump. If your heart isn't pumping this huge thing, you're not feeling this bounding blood pressure in your chest, right? And so a lot of times what happens to people who are feeling impulsive or aggressive is they have this internal way of feeling their whole body get pumped up, right? And then they're pumped, they really get pumped, and then it's as if it positively feeds back on them and makes them more aroused because they're feeling their heart go, and they're feeling their blood course, and they're feeling all flushed, and they move. And so it's nice if you can dampen down these peripheral symptoms, and of course they have no heart problems, and they don't have low blood pressure, and they're not going to faint on the ground in front of you. It's nice to be able to work with the peripheral effects of these agents that also actually help increase attention and arousal. You might get two mechanisms working to bring somebody's arousal down. So for instance, if you have a tip skill, right, and you're planting, somebody's face in ice water, that might be helpful, but you might not always have ice available. So this is a nice way, if the person is healthy and can manage it, to actually bring down physiologic arousal, even at baseline. Okay. Annie, I just want to say, Annie is a young client of mine with panic disorder, particularly around opening emails and doing anything that's school related. She's at a competitive college, doing very well, and yet would not open emails from teachers and classmates about projects. She had major depressive episodes, she had somatic GI, she had Lyme, she had MRSA, she had a terrible year. I mean, she had to pull out. It was a very, very difficult year for her. And one of the medicines that we had tried over the years, looking at the old stuff, were SRIs, and I had tried Lexapro and Celexa. But I started her on guanfacine. Guanfacine is an alpha-2 mediating substance, and she now says, look, I have more energy, I'm more focused, I am less avoidant, and it has a more stable effect. She would feel lows at the end of the day. It doesn't bother me, and it doesn't change my personality as much as these other medicines did. Okay, so just so if we use DBT skills, right, I'm sure you've seen the top part of the slide for people who have actually been in DBT, which is when you are emotionally charged, you want to decrease your physiologic arousal. You want to take your attention off the thing that's making you mad. And you want to inhibit the impulse, okay? Whether it's the impulse to scream, the impulse to kick, the impulse to drink a bottle of wine, whatever it is. You want to do all three of these things. You want to stop your mind from racing. In my work with people, I also get them in this very moment to reappraise what what their choice is or what their thought is dialectically, which means what are 100 different interpretations, what are 100 different solutions, what are 10 million other things you could do. I'll settle for 20, you know, that kind of stuff. What value do you carry? Who do you want to be? Is it an opportunity for you to be that person right now as you're thinking through it? What skill, what groups of skills can we use to get you to stop being in this heat of the moment with a script already written, and what can we do to kind of slow it down? And these meds help those that otherwise can't access this part. Okay. Valerie says, Valerie was on Clonidine, okay, which is another alpha-2 drug, and Clonidine is good for restricted settings. You know, both of these drugs you administer once a day. So I don't get a drop in my stomach anymore. My thoughts, what's my thinking? My thoughts are less focused on loss. I'm no longer lost in sadness, even though I didn't have much to be sad about. I think she could get herself out of the cycle a little more easily. I feel less impulsive, and then she whacks about perhaps why. So, and she had been on other SRIs, other anxiolytics, other agents that had not offered much benefit. Beta blockers, just to mention. Now, they don't really have a direct effect on anxiety, but they're interesting. Again, they decrease the patient's preoccupation with their bodily state. You've probably heard about people taking beta blockers for performance anxiety, right? I'm going to speak, I'll take a beta blocker. I just put on lipstick, by the way, but I don't use beta blockers. Okay. And it relaxes blood vessels. What's interesting about beta blockers, and I'm sure there'll never be a trial on this, is that if you give somebody a beta blocker after emotion, like there's been a study where you show an emotional event and then you also show a non-emotional event. And you have somebody recall both events. The non-emotional event somehow is recorded and retrieved in more detail than the emotional event. You give the person propranolol or a beta blocker, and now they actually can remember that emotional event with as much detail as the non-emotional event. And so it actually decreases emotional salience and allows somebody to have then a narrative about it. It's not, you know, the thing is it doesn't just get the bad memories, it just gets any emotional memory, so it's not really good. But the neat thing is that if you can find a medication, maybe we will, that allows somebody to take something from the kind of the body, the amygdala level, the nonverbal level, and verbalize it, then it might be that that memory gets to be put in a narrative without as much consternation and emotional misery. And this is what long-term exposure treatment does. I mean, it's the same, it's what eventually happens with that kind of treatment. It would be wonderful if we could do it with medication. Okay, let me just, Pendulal. Pendulal is interesting. Pendulal blocks serotonin, oops, what did I do? Block, where am I? Okay, I've jumped a bunch. Okay, I'm gonna, Pendulal, I started using Pendulal in prisons, right? And basically just what can you do in prisons where you can't really see people when they need to be seen very often and they have one med line. What are you going to do when you can't monitor blood pressure? Pendulal is also a way to decrease the peripheral arousal in people so they don't kind of jack themselves up. There's some support for Pendulal. This Sarah on Pendulal said people can get a word in around her. She doesn't rage and scream. Her relationships are improved. Okay. This you're not going to be able to read at all, but I just want to show you it's interesting. If you look at aggression studies in rats, these are isolation studies where they're in a room by themselves and any rat coming in is seen as an invasion of their privacy. The meds that most consistently decrease aggression buspirone, 5-HT1A, serotonin agonists. They completely inhibit the aggressive behavior, irrespective of their intrinsic activities. Buspirone, Buspar. Prazosin is an alpha-1 antagonist. What's really interesting about that is it's starting to show, the VA is starting to use it for vets with nightmares. Prazosin decreases nightmares, and interestingly enough, it also decreases aggression, at least in rats. I haven't found a human study, but when I have somebody who has nightmares, I'm aggressive, I might see, since it is indicated for, I'm not sure if FDA approval though, it might be off-label. Clonidine, okay, I've talked about that. Clozapine, all right, are helpful in decreasing aggression. Okay. Last med to go through, okay, Buspar, again. Buspar started out as an anti-anxiety medicine. People were really thrilled to use it, and then they thought, oh my God, it does nothing. It really does nothing. It takes forever, it does nothing. People are saying it does nothing. Well, I think it actually does do something, and it does do something after 3 or 4 weeks. But what's interesting in open label studies is it does decrease aggression. We don't have a randomized placebo-controlled trial on it, but it absolutely decreases aggression in rats. Again, I'm sorry to say, but in open labels, 10 to 25 milligram a day in non-organic patients, small n's. These are like 9, 14, 21. They're very small n's. We don't have anything better. But have been shown to decrease aggression. The major side effect is you get dizzy. So you kind of just titrate them up until this point where they get dizzy and you back off. But if you have somebody who's really aggressive, this might be a very good thing to try. The other thing is it's well tolerated. The no effect, right, means that there's not a lot of side effects either for many people. Okay, so back to these guidelines. For me, what I'm doing is I'm looking for the partial serotonin 1A agonists, buspirone and Pendulal. I don't know if we need to, name all these things, but for 5-HT1A antagonists and B agonists, propranolol, I'm looking at prazosin, I'm looking at clonidine, and guanfacine. Guanfacine being I go to more than the clonidine. Although I have more experience with clonidine, less with guanfacine. I think it's an easier medication. Clonidine causes sedation. That might be great for people who have trouble sleeping. All right. So for a lot of our clients who have trouble sleeping, you might be able to get 2 symptom alleviations with 1 drug. That would be nice. But for people who don't have trouble sleeping, guanfacine is the one I'm going to. Lamotrigine, clonidine, and guanfacine also are helpful for perceptual symptoms, cognitive distortions. So that's where I'm moving to. The side effect profiles are much better tolerated. Weight gain isn't a problem. We're not looking at metabolic syndrome. I don't have TD to worry about. I can't tell you how many people have come in on antipsychotics having never been consented for tardive dyskinesia, which is a permanent neurological, progressive, if the medicine isn't stopped, illness that we don't have the treatment for. And so it's really important that we're using as little medication as works, as little medication as to help the person rein in their attention, rein in their arousal, rein in their thinking, so that I can then use therapy, use DBT therapy, use whatever other effective therapy there is to help them manage their impulsivity and their aggression. So I'm going to stop right here. It's been a lot of talk.
We do have about 10 minutes for questions. We will also have Dr. Ganizadeh with us at the panel at the end of the day, so if you don't get all questions or if you have other questions that you don't have a chance to turn in, you'll have another opportunity. But if there are, I'll take first questions right now, if anyone has written anything down. I should have reminded you before to write your questions down. Are you out of the cards? Oh, that's a problem. Why don't I...
if no cards, I'll do my case study.
Is that the issue? People don't have don't have cards. Let me just send, oh, there's some coming this way, so let me send some back the other way. Why don't you send some of those down, and we can get that going. My apologies for not getting that there. I've got a first question, which is, how can this get to, I think this is probably the biggest question that many of you may be writing, so hold a moment. How can this get disseminated to the psychiatric community?
You know, one of the wonderful things about this talk is this was kind of all my own thinking. I've not read it anywhere. I've not really seen people approach it like this in anything that I've read. So you're getting my thoughts as a psychiatrist, as a DBT practitioner. I'm not presenting anything that has a profound evidence base either. Just to say, so this is a small clinical practice and this is what my experience is. So I would probably need to write some case studies and submit them. Or give talks like this and engage in discussion and see where it goes. It's interesting to see what Dr. New has to say about this, or other prescribers.
Would you please share your thoughts on using benzodiazepines with BPD?
Yeah, interesting. Benzos are interesting. They're pretty safe, except for the propensity to get addicted. What I think, and people say, and I say you get a couple IQ points dumber when you're on benzos. Things just don't stick. You don't kind of care as much. Over the long term, there really hasn't been anything too terribly devastating about benzos except their addiction. I never give Xanax, ever. I am never going to give anything that has such a positive reinforcer to popping a pill, ever. I'm not. So I never prescribe Xanax. I get people off Xanax as fast as I can and I put them on long-acting benzos. But the interesting thing is, I was just reading some studies that show, remember I was talking about the hippocampal connections and the ratio between the hippocampus and the amygdala? There was a study that I read that said that benzos actually they inhibit long-term potentiation of the hippocampus. So what happens is the association to the cortex and new learning doesn't happen when you're on benzos. And I think that's borne out in clinical trials. If you look at treatment of benzos for anxiety disorders versus CBT, the benzos is good and helpful for as long as the person's on the benzo. It's the CBT and the treatment that actually has the longer treatment effect. So I just try not to use them. If I have to, I do. Sometimes there's nothing else out there that's as beneficial, but I really try to move away from them quickly.
If meds like guanfacine are the path to the path, at what point do you discontinue the medication and refocus on behavior?
Perfect. When the person has the skills down, when we can slow that moment down. Sometimes I don't even have to go on it. I'll give you a quick example. I have a 26-year-old woman who keeps thinking I'm crazy, I mess up relationships, I can't control things, I make people like me too much, and then we're boyfriend and girlfriend too soon. Oh my God, I'm crazy, I can't do this. So this guy doesn't call her, invites her for lunch, doesn't call her. Oh my God, should I call him back? Should I? She wants to call him 20 times. What's up? Why are you late? What's happening? A lot of anxiety. We did work on what could be interpretations for why he didn't call you. You have to come up with 20 interpretations. She comes up with 20 interpretations. This is the dialectical thinking. It's also distress tolerance management. You have to choose one and act on one. She decides, okay, he fell asleep. She invokes, I don't want to be a nervous Nelly around a guy not calling me back. I have no trouble with my girlfriends not calling me back. Why am I such a dribble of, weakness, to use her words, when the guy doesn't call me back? So we invoke all powerful role models. A friend of hers doesn't, is fine. If the guy doesn't like me, I don't want him back, I'm fine. She moves on. She's gone through the moment. She doesn't need guanfacine. But if she couldn't do that before, I'd give her guanfacine to help her get, to get through. So those are my measurements. Those are my objective measurements. Yeah.
Will there be any more tests available for checking levels before prescribing? Blood tests, that sort of thing. There's a question. The person mentions that a naturopath that they consulted with sent away for a test before prescribing?
There are, for things like mood stabilizers, you want to get liver function tests, you want to get levels of, you want to get baseline levels of blood and renal activity, things like that. We don't have really good, the study of the brain is young. We don't really have good measurements to tell us what is the right therapeutic dose for medication. So at this point, except a few, like lithium or, we don't really have that down.
One question here. Do you have recommendations for how a non-prescribing clinician, therapist, use this work with their clients? Any recommendations for that? If you're not the prescriber, how might you use this information?
Well, I think anybody who is seeing, a psychiatrist or other physician or nurse practitioner, we want you to be educated. We want you to be educated about what the medicine is for, what it does for you, what your alternatives are. It's really a valid consent process, and that's not happening. Yes, the other day I went to a doctor who gave me a coupon for a drug and didn't even tell me the name of the drug, didn't even tell me the side effect profile or anything. I was really amazed. So I think really insisting on a valid consent process, including I went to this lecture and I heard about X, Y, and Z, and I really think I need help with attention and arousal problems. What medication are you giving me? How will it help me for that? This doesn't seem to be it. I would like to try that. Do you have any recommendations? I mean, I think conversations like that need to happen.
Can you comment on medications in the case of bipolar NBPD, I think comorbid bipolar BPD patients? Can there be a conflict here in the prescribing?
Well, my philosophy is to give as little medication as works. So if somebody really does have a bipolar illness and is cycling and has had multiple episodes of altered mood states, then data would show that they need to be on medication in order to, stably. I don't think that the medicines I'm talking about actually would interfere with learning, although I don't have a long enough time to really say anything other than that's theoretical.
We have a specific question. Someone is asking about dose equivalence. They're using Lamictal, and it looks like 50 or 200 milligrams. What's a dose equivalent of clonidine or guanfacine? That's very specific.
It is. I think what happens is that the physicians want to help. They want somebody to be less anxious. They're going to give them a medicine that hopefully will be helpful in kind of dampening the mood or stabilizing something, helping somebody sleep or think a little more clearly. And they're going to give, since there's no absolute therapeutic dose, they'll probably give a little and see how the person does clinically. I mean, I think that does make sense. That dosage of Lamictal isn't within a therapeutic limit for something like bipolar illness. However, it doesn't mean that that's not a sufficient dose. So I think it's a conversation that's ongoing between the prescriber and the person who's taking it.
A final question, perhaps speaking for a lot of people. Are you taking new patients? How do people contact you?
Thank you.
Thank you very much, Dr. Cadiz. There will be again more.